Welcome back to another episode of the Back to Square Quan podcast. Today we have a very special guest. I think very special and guest to talk about a very important topic since the pandemic or the endemic COVID would be with us for a while, I guess. So I've invited Dr. J. Bhattacharya. Am I pronouncing your name right? Hopefully I'm not butchering it. To speak upon matters on all things related to COVID. So before we start, Dr. J, can you share with us a little bit about your background? I think just drop some credentials because first of all, neither Chung nor myself are doctors. We just like
Kedrick's on the way.
Yeah, but I'm only doing like exercise science, so I'm not the useful kind of doctor, especially during this time. So yeah.
I mean, medicine has not had the very best pandemic, I have to say. But I am a professor of medicine at Stanford University. Actually, now I'm officially a professor of health policy. For 20 years, I was a professor of medicine. I have an MD and a PhD in economics. I do research full time, and for the last 20 years, my research has focused on epidemiological issues, health policy issues, a whole range of them, but including especially infectious disease epidemiology, published on back since HIV was one of my very first published papers. And I've been working on infectious disease epidemiology for forever now. And certainly during the pandemic, I've worked a lot on COVID epidemiology and COVID policy.
Yeah, that's great because I think that, it's important, I guess, for people to know that you've at least worked in the field because apparently nowadays only if you are a virologist, immunologist, or whatever, you apparently can't comment on things like that, even though, you can't even have a conversation about it. So it's good to know that between the three of us, at least one of us has the necessary credentials. Yeah.
Well, I think actually that is a major problem in the discourse that's happened during the pandemic. The issue is that this pandemic and the policies that are adopted are not simply a matter of epidemiology, virology, or immunology. I mean, those are important fields that have important things to say about the right thing to do during the pandemic, but they are not the whole of what the pandemic policy entails. The policies we've adopted have affected the lives of every single person on the face of the earth in one way or another. And the expertise needed to understand that includes people who study economics, people who study sociology, people who study psychology, people who study psychiatry, people who study, you name the field. If it touches, the field has been touched by this pandemic in some way, and to exclude all of those people, all that expertise from the discussion has led to a impoverished discussion about the right policy for COVID.
And so I do have a question for you, Doctor. So obviously, when Kedrick told me, I was astounded. I was very excited to get on this conversation. Of course, being a professor yourself and being so heavily involved in so many fields, obviously one of the co-authors of the Great Barrington Declaration. And I guess did it come to that point? Throughout the pandemic and stuff like that, when you and the co-authors kind of realized that a lot of the policy makers that have those policies in place weren't really considering the other sort of like things that you've mentioned, right? Psychology, socioeconomics, and all that kind of stuff. And they were really, really just sort of focusing on how can we get rid of this virus rather than thinking of humans in general.
I mean, that I think is exactly right. It's what's happened is that the people that have been in charge of the COVID policy have been utterly blind to the harms the policy entails, and they prided themselves on the blindness. What they've said is that if you can get rid of COVID, if it doesn't matter any of the other things that happen as a result, because if one life saved from COVID is worth an infinity of lives saved from depression. I think that this it's essentially kind of moral blindness, right? So that's fueled by both by the fear of COVID and also the sort of this disciplinary focus of the few people that are in charge of COVID policy, right? So they have made a virtue of this blindness to say and used it to exclude from the conversation for instance, the tens of millions of people that have been thrown into poverty as a result of the COVID policy the world has adopted, the hundreds of thousands of children dead from starvation as a consequence of the COVID policies that we've adopted. When we talk about these harms, they're not simply harms that are like economic in nature. That, like, you know, it's the kind of moral calculus people have pushed through the whole epidemic is, well, we're worried about lives on COVID, and you're just worried about trivial economic things. Well, it's not trivial economic things when you make $1 or $2 a day of income, and you live in a poor country. You get thrown into starvation. It's the life of your child that gets harmed. That you can't send them to school. The school is closed for 2 years. These are consequences that last a lifetime, often resulting in death or other very, very bad outcomes on the other side. The conversation about COVID policy has always been lives on one side and lives on the other, not lives versus money. And I think a lot of the harm has come from that blindness.
Yeah. So the central premise of like the Great Barrington Declaration focus is on like focus protection. So I think we will talk a little bit about that, but I do think it's very important to like talk about your initial work on the pandemic, right? So when you talk about like the seroprevalence study at the start, so can you maybe share a little bit about that, and of course share with our listeners what does seroprevalence mean, because our listeners are quite like
sure, happy to tell. So basically, the in the early days of the pandemic, we didn't really know. Let's say in January, February of 2020, we didn't really know what the death rate of the virus. And now we thought we did, because what came out of places like China and Italy were the number of people that died apparently with COVID. And the denominator was the number of people that presented to public health authorities as having COVID. Right. So this is before the PCR tests. So they would do like lung X-rays, or if you check for symptoms. The estimates of the death rate was very simple. How many people presented that looked like they had COVID in the denominator, and the numerator, how many people died of that set. And you get a death rate that the World Health Organization reported something like 3-4% in the early days of the pandemic. That is an incredibly deadly infectious disease. It panicked the world. The problem with that number is that a very large number of people had COVID and didn't know it, because the disease presents with a very wide range of clinical presentations. 30-40%, I'm not sure exactly the number, there's some different estimates in the literature, but have COVID and do not have any symptoms at all, ever. So they've had the virus, they have antibodies in their bloodstream that indicate that that they were infected with the virus, but they can recall no symptoms, or maybe they're so mild they don't remember them. Most people who had COVID have some symptoms, including fever, cough, some with a loss of sense of taste and smell, but they recover. Never go to the hospital. A small fraction of the patients end up going to the hospital because they have a severe viral pneumonia, and unfortunately, some of those also die from that severe viral pneumonia. In the early years of the pandemic, always the attention was focused on sort of that small fraction of patients, and all these other patients that had the disease recovered completely, but never came to the attention of public health, were not included in that death rate estimate, the death rate estimate that panicked the world. I'd done some work in H1N1, in the 2009 epidemic. A similar thing happened there, actually. In those early days of the pandemic, in 2009, of the H1N1 pandemic, there were similarly high death rate estimates put out by the World Health Organization and other medical bodies about the death rate from H1N1. What happened was that a whole series of studies were done of the levels for the presence of antibodies in the population at large to the H1N1 flu. So antibodies in someone's blood that's specific to H1N1 provides evidence that you were infected and recovered, right? Those are called seroprevalence studies. Sero meaning blood, prevalence meaning how common is it in the population. Seroprevalence in this case was seroprevalence of antibodies in the blood indicating H1N1. Now, the seroprevalence studies that I've focused on now since in COVID has been on the presence of antibodies in the blood indicating COVID infection. And when, in H1N1, when those seroprevalence studies were done, it turned out there were 100 or more infections for every case that had shown up. And so the death rate was actually something like 1 in 10,000, not 1 in 100. 2 orders of magnitude difference. Now, there's some fight over exactly the number, but I'll just give you a sense of the order of magnitude, 100 times more. And so in the early days of the epidemic, I had a similar idea that, well, maybe this disease, which spreads, looks like it spreads an awful lot like H1, like the flu, it spreads via aerosolization. We don't know the death rate. You could do some certain calculations based on like the Diamond Princess cruise or the numbers out of China, and get some guesses. But until you have these seroprevalence studies, you cannot know the true death rate from this. So I helped run as a senior author the seroprevalence study in Santa Clara County, which I think was the first one with that made a big splash, and then another one in LA County, where what we found was that it wasn't 100 times, it was more like 30 or 40 or 50 times more infections than cases. The infection fatality rate turned out to be in Santa Clara County and in LA County in April of 2020, 2 out of 1,000 rather than 2 out of 100. Right, about 10 times difference so more than 10 times difference in the actual infection fatality rate. Now we looked at a community dwelling population. The infection fatality rate in nursing homes is higher. So we didn't do a study of that, and that's if you do the estimates in the U.S., maybe the infection fatality rate might be 0.4%, 0.5%, something on that order. If you include the nursing home population worldwide, there's now 100 of these studies, and the infection fatality rate turns out to be about 0.2% worldwide. The median infection fatality rate in 2020 from before the vaccines.
Yep. So just to kind of clarify, essentially, infection fatality rate is how many people die, how many people that got infected died, right? So,
Yep.
And these studies are prior to the vaccines. Obviously, with Delta and like the vaccines, things get murkier. But now with the latest like Omicron, I mean, just based on what you're saying, it seems that the infection fatality rate would drop because more people are getting infected, but less people are dying. So with the value of like 1.3 actually dropped because obviously with vaccines, previous natural immunity from which we will talk about, do you think that the infection fatality rate will go up or will it go down?
I mean, with the vaccines, it goes down, right? The vaccines do an excellent job of protecting people against severe disease and including death. So the infection fatality rate now, especially in heavily vaccinated populations, is going to be, if the vaccine is 90% effective, then the infection fatality rate will be 10 times lower than what we measured in the early days of the pandemic without the vaccine.
Yep. So I guess it brings us to the next conversation, right, on like focus protection. So with these people that are actually like dying from COVID, there is like a particular like characteristics, right? A large majority of them would be either have one or more comorbidities, and they're probably like age is a factor as well. So can you maybe share a little bit about that? Because people was like, oh yeah, infection, this is the infection fatality rate, right? The IFR, right? And they'll be like, oh, if it's 1%, I may still have a chance but what they don't realize is that if you're young and healthy, right, the chances are actually much lower. So maybe can you share what are some certain general characteristics that that people tend to get either severe illness or death from getting this virus?
Yeah, so the single most important risk factor is age. By far, it's not close. So just to give you some sense of this, every 7 years of age that you get older, it doubles the infection fatality rate. Every 7 years of age doubles it. So at 50 years old, it's like 0.2% more infection fatality rate, 99.8% survival. At 57, then it'll be something like 0.4, at 64 it'll be 0.8, and so on, and then it halves on the way down. So 43-year-olds will be 0.1%. That is the most important thing. Now, comorbidities do increase your infection fatality rate. So I think obesity, for instance, I think increases it, maybe doubles it. So those are important as well. But the key factor is age. There's almost 1,000-fold difference. Again, this is before the vaccine, and actually even with the vaccine, in the infection fatality rate of this disease from oldest to youngest. This is a disease that really, really harms older people and is much less fatal in younger people. That's like in some sense, it's like it's much steeper than the flu. The flu is more deadly to young people, relatively speaking, especially children. Can be depending on the particular strain, and for older people, it can be deadly. Of course, it's more deadly for older people. The flu is more deadly for older people, but the slope is much steeper for COVID. 80%, something like that, 70-80% of the deaths in the United States from COVID have happened to people that are over 65.
Mm-hmm. So that I've got this actually just literally just popped into my head because we were obviously comparing sort of like COVID versus sort of like the flu, and I'm pretty sure it's sort of the same in the States to New Zealand, where when winter rolls around you get your flu shot, and it is interesting on what you said because generally flu tends to be more deadly to the younger generation, kids predominantly. And
well, I mean, flu does kill older people more than young people. It's just that the slope is steeper for COVID, right? So I think like if there's some age below which the flu is more deadly, and above which like COVID is more deadly. Yeah,
gotcha.
Like there's a crossing point. I mean, certainly for children, I think the flu is more deadly than COVID, and certainly for old people, COVID is way more deadly than the flu.
Yeah, so that's interesting. So on that note, I guess in regards to the future and sort of like into the great unknown, as people would say, it is obviously very common these days to sort of like get flu vaccinations. You get your annual sort of like flu vaccinations, and there's this, I guess, this whole very big conversation with like anti-vax, and they don't want to get the COVID vaccination, and we've got the group that like will get the COVID vaccination just because. I guess in your opinion, do you foresee going into the next decade or so, highly likely COVID being more of an endemic thing, and it having that opportunity or potential to develop multiple variants as it evolves, as all viruses do? Would you think that COVID vaccination would be like an annual thing as compared to something like an annual flu vaccination?
Well, one of the things that's different about COVID than the flu, the way it mutates, the prior infection with one variant of the flu that provides very, very incomplete protection against future variants of the flu. That provides some protection, not some cross protection, but it's not. It's sort of insufficient, I think. And that's the argument for the annual flu vaccine. The flu mutates in a particular way every year, and it's hard to predict. But so, like for instance, in the southern hemisphere, the flu hits you all in your winter, our summer, where I'm in California, and the flu vaccines that are used in the northern hemisphere are based on the variant that hits the southern hemisphere during your winter, our summer. So they formulate it on that basis, and the way that the flu mutates, the fact that you had the flu before doesn't necessarily protect you a ton against having against the next variant of the flu. And it depends on how severe it is. It varies from year to year, and so that's the argument for the annual flu vaccine. COVID is different in that sense. COVID prior infection provides very strong immunity against future infections. It's in the same way that you get immunity from other coronaviruses. Now, the immunity doesn't mean you won't get reinfected. You can still reinfected. I think before Omicron, the reinfection rate was something like 1%, 0.3% to 1%, 1 year after infection. Omicron clearly evades both natural immunity and also vaccine-mediated immunity. A lot of people that are vaccinated and a lot of people who were previously infected are getting reinfected with Omicron. But what both the vaccines do and also natural or the pre-COVID recovery does is it provides you protection against severe disease if you get reinfected. So you'll get something much closer to a cold the second time than the first time. So it'll now it's hard to say exactly because this is a novel virus, and who knows it might require a new vaccination from time to time, depending on how it evolves. But my best guess is that it will become because if you have a population that's well protected immunologically, either by the vaccine or by natural infection and recovery from natural infection, or both, the experience of reinfection will be much milder. And so why take the risk of a vaccine if you're just protecting against a cold? We don't have vaccines against a common cold. It wouldn't make sense. You'd rather just get the cold than the side effects of the vaccine, which are very similar to the cold. I think that's the long run of COVID, not annual vaccination time and time again, but just like reinfection every few years with it, where it's like a minor inconvenience because you've had this recovery from it in the past or because you've been vaccinated in the past.
So just to continue off a point that you mentioned just now, so vaccines and previous immunity, they do not do a good job, right? Obviously, they reduce in a small percentage, and obviously less with Omicron to prevent reinfection, which means that it does a poor job when it comes to so-called, when people say, I take the vaccine so that it protects people around me and like prevents or stops transmission, right? But what the vaccine does is that it protects the person who takes it, right? The main benefit is for the person who takes the vaccine. So I think that's kind of like important to clarify, because in the mainstream media, people will always be focusing on antibodies. They say, oh, cool, antibodies wane, right? Against Delta after, based on like the original like wild type strain, it's like cool, right? 5 to 6 months. And then with Omicron, it's half that time. That's why we need to take another booster. But those are just measuring like certain antibody titers, right? And there is a difference between like your immunity, right, your memory T cell, B cells versus those antibodies. Can you like maybe shed some light upon like those differences and why it's actually important for people to conceptualize in that manner rather than focusing on just either one or the other?
I think antibodies are what would in medicine we call a surrogate endpoint, right? So you can have antibodies, and that provides some evidence that you're protected against the disease. In this case, because the antibodies actually are, if they're specific to COVID, can be active in protecting you against the disease. But you can also not have antibodies and still be protected against the disease, because there are other mechanisms in your immune system to protect you against disease that are beyond simply just antibodies, T cells and B cells, a whole range of other. So like the antibodies are only one component of the immune protection you get in immunology. So that the fact that it's present or not present is not the relevant question. The relevant question is, what does clinical disease look like for someone who's had disease and recovered versus someone who hasn't? What does clinical disease look like for someone who's vaccinated than someone who hasn't? Right? That's the relevant question. And there, the evidence is abundantly clear, right? There's a huge amount of evidence from around the world that COVID recovery provides very, very strong protection against severe disease. With Omicron, it now, I think, doesn't provide protection against getting infected again. But if you get infected, it's likely to be mild, especially Omicron by itself. It seems like it's 10 times less deadly than the previous variant. So it's mild on top of mild, right? So it's 10 times less because you're previously infected and protected by your immune system, and then 10 times less deadly because it's Omicron. By the same token, the fact that antibodies wane after you get the vaccine is not evidence that you're not protected against severe disease. You can get infected again, absolutely, even if you're vaccinated. I personally was vaccinated in April of 2021 and got COVID with Delta in August of 2021. And I wasn't hospitalized. I had it wasn't pleasant, but it wasn't, it didn't, I'm still here. Right. So I think that there's a popular misconception both about how to tell if you're protected. If you're vaccinated or recovered, you're protected. and the nature of that protection. The protection, it doesn't fail against the thing we all mostly care about. The thing we mostly care about isn't, am I going to get sick? The thing we mostly care about is, am I going to die from this? Am I going to be hospitalized from this? Am I going to be permanently damaged by this? And both the vaccines and natural immunity protect against those bad outcomes, even if it doesn't protect against getting infected.
Yep. Yeah. So I think that's like a very like important distinction, because, you know, even in New Zealand, people always just little kind of like background is that in New Zealand today we just had our first two Omicron cases in the community, and obviously people are like freaking out. And the message from like the Prime Minister or on the media is like, 2 doses of vaccines protect against Delta, but they don't do well against Omicron. So go out and get your boosters. And I don't think that this is not to chastise our Prime Minister, but that is generally the mainstream message, right? This is what people say. So I think you mentioning the distinction between actual protection is very important, because when you talk about this virus being sort of like, it affects life from a multifaceted approach, right? It's just not just the virus affecting someone's health immediately from the virus. You also have things like mental health, you know, which like lockdown places.
How much time have you spent in lockdown over the last 2 years? Like what fraction of your life?
I can actually speak very clearly to this, because a little bit of background is that I'm from Malaysia, so Chong and I were both from Malaysia, but I came here much later to New Zealand to do my PhD, and so I actually count the months, because the months we spend in lockdown, I can technically apply for like a leave, right? So in total, I would say probably close to 10 months in total.
10 months in lockdown out of 2 years. I mean, it's a remarkably large fraction of your life spent basically not being allowed to live your life.
Yep.
In pursuit of a policy where to protect you from a virus that you're going to get anyways.
Yep.
Yeah.
So I think it's, and it's not just a policy that's benign, right? In the United States, the CDC in July of 2020 did a survey of the United States and found that 1 in 4 young adults, people your age, seriously considered suicide. The level of depression and anxiety has skyrocketed everywhere where there's a extended lockdown. And imagine I just imagine living under this, because I've lived in California, I don't have to imagine it. The continual uncertainty about, can I live my life? Right? Is there going to be another lockdown? Can I go on with my business? It is not it's not a benign policy. It's a policy that has destroyed the lives of many, many, many people. And to characterize it as the safe alternative it's a mistake, a huge mistake, because it essentially says all purpose in life is focused on the avoidance of this one single infectious disease, as opposed to the plural purposes that we all have in our lives. And I think I think we have to get away from thinking about lockdown as benign intervention. Anyone who's lived through it understands it is not a benign intervention.
Yeah, it's interesting because so like Kedrick said, I was also born in Malaysia, but my dad, who's actually originally from Hong Kong, and Hong Kong has this big thing about I'm sure you're very aware of, like, keeping it COVID zero. And so my dad hasn't seen his mother for like years, and neither have I. And she's at that age where she's way past 90 at this point. We don't really know when she's going to go. And I think like policies like that makes it so hard, because in order to get into Hong Kong, apparently you need to be quarantined in a room for close to 3 weeks. Now, I don't know about you, but 3 weeks is a long time in a room, and not to mention if my parents are still working and stuff like that, like 3 weeks is a big time. And it's so interesting because apparently there was a news, I think yesterday or this morning, where they basically culled about 2,000 hamsters in a pet shop because it was apparently related to COVID. And it is quite scary to know that there are still I guess countries in the world, and to an extent New Zealand, when Delta hit as well, still think that lockdowns is like the solution. And as Kedrick said, Omicron has just hit our shores today. From where I see it, it's like, it's not, like, as long people are taking care of themselves, either from vaccination or recovery, it is going to just be, it is what it is, and putting people in lockdown. And I've seen friends and clients of mine who literally have, lost houses and family, just because of COVID. And I guess my question there is, how would you convince sort of these government bodies to kind of say, like, look, COVID is here to stay. It is much better for the world to live in a, as it is and go on, rather than just trying to get rid of the problem, which clearly isn't going to go away.
Well, I think the political problem in Australia and New Zealand is actually, in some sense, it's like it's a problem created by early success with that zero COVID policy, right? So what happened is that COVID hit in, say, February, March of 2020, in the developed world, around the world outside of China, during your summer and during our winter. So during your low COVID season, that's when the COVID pandemic hit. There were not very many cases in New Zealand and Australia at that point. You all have fewer entry points. You have some ports and a couple of international airports. It's much easier to lock yourself away as an island nation than it is for a country like the United States to lock itself away, especially during COVID season, where the disease was already pretty widespread. I mentioned that seroprevalence study that I did in April of 2020 in the United States, in LA and Santa Clara County in California. There was already 3% of the population, 3 or 4% of the population that had evidence of COVID, even in April of 2020. So by the time we started a lockdown in March of 2020, it was already too late. It had already gotten to the point where there was no chance of getting to zero in the Northern Hemisphere during high COVID season, where the disease had spread outside of the knowledge of public health for a while before the lockdown happened. Unlike the United States, unlike Europe, unlike South America, COVID didn't spread in New Zealand in the early days. It would hit during your summer, low COVID season, where spread is less likely. The few cases you had, you isolated and you got to zero. But you had to stay locked down. You had to keep the whole world out in order to stay there. So expats couldn't come home even to bury their family members, right? You had to essentially isolate yourself from the world. And even then you still had outbreaks of COVID because you can't actually isolate yourself entirely from the world. The vaccines couldn't have been developed in Australia or New Zealand. The reason is simple. It's not because you all don't have fantastic scientific facilities. The problem is, in order to test the vaccines, you need places where there's lots of cases. You cannot run a randomized trial on a drug or on a vaccine in a place where there's no cases. You have to have the cases. So even the strategy to get out of it, which is use the vaccines, had to be developed in a place where there was COVID. So you have a completely unsustainable policy, and you're locked into this policy because now the political fortunes of Ardern and Morrison and others, it depends on keeping COVID out. But you see the fruits of that in Australia. Australia has one of the very highest COVID case rates in the world right now, and that's during your summer, the low COVID season. It's because you have a population that doesn't have a lot of natural immunity. Now, fortunately, and thank God for this, both Australia and New Zealand have had enormously successful vaccination campaigns. And it's also likely to be Omicron that spreads, not Delta. And as a result of that, you will have less death and harm from the COVID spread, which is a hugely good thing. It's so I think those two things together, ultimately, I think Australia and New Zealand will have weathered the COVID storm better than much of the rest of the developed world. But it's not, I don't believe, a policy success. It's that can be replicated outside of the circumstances we just talked about.
Yeah. So just to kind of like correct myself. It's actually closer to 8 months rather than 10 months because I don't want people to like, dude, this guy's spreading misinformation. So I think it's like important for me to clarify that. But in my justification, they say lockdown make you lose track of time. So I'm just going to blame it on the lockdown, making my awareness of time go bad. So it's
Kendrick,
closer to
8 months out of what, like 20 months is a huge fraction of your life.
Yes. And
you're young. I mean, that's the other thing for the lockdowns have affected kids and young people the worst. Right. I mean, you should be living your life. I mean, I'm an old guy. It's fine if I'm a hermit and like I don't see anyone except my family.
You've done everything that you need.
I'm done with my but I mean, young people should be living, I think.
Yeah. It's interesting because sorry to cut you off, Kedrick. I was literally at the physio yesterday, and I was talking to a physio, and she said she's just graduated. She's working obviously, and she was saying a couple of her mates who got into physio in the first year of COVID had such a huge difference in terms of how the course was actually being delivered, because they were still complied to do like 1,000 hours of 10,000. I can't remember the exact number, but a lot of hours of like hands-on work. But because of COVID, they had to keep pushing it back. And it was just such an interesting, well, not interesting, it was actually quite devastating to see actually the younger generation who, for the kids especially, who, hey, it's my first day of school, sit down at a computer, it's like time to Zoom for the next 8 months. It's rough.
Well, I think it's heartbreaking, right? So like the lives of young people have been utterly overturned by this. I don't know exactly the policy regarding schools in New Zealand, but in California, for almost 18 months, especially kids going to public schools, didn't have in-person schooling. Stanford, where I'm a professor, we had classes remotely. A lot of like lab classes didn't happen really. The opportunities for students to interact with each other, which is where much of the learning and sort of benefit of coming to a place like Stanford didn't happen. Very little time spent with professors. Zoom is not a substitute for actual in-person learning. And the consequences are, again, not just simply just, you're inconvenienced. So poor kids in California, especially, were more affected than richer kids, because richer kids, that private schools were less impacted by school closures. If you're richer, you could afford a tutor for your kids. And the long-term consequences of that school disruption is, it turns out from the health economics literature, there's really strong evidence of this. Long-term consequences of school closures are things like shorter lives, less healthy lives, poorer lives. The ripple effects of even the short-term school closures will echo for a long time, and it will hurt the poor more than it will hurt the richer kids, because they were more affected by it. This is like enormous generator of inequality. These lockdowns, the way they actually work.
Yeah, 100%. I completely get that as well. So not to mention like so I think 2 years in the pandemic, right? Malaysia had like attrition rate of like 20,000 people like stop going to school. That's 20,000 kids like not going to school, for in the span of 2 years. And Malaysia is a relatively small country, it's like population of 30 million. It's bigger than New Zealand, but it's not as big as the States. I think California has more than 30 million people or something like that. So I think it's very important to like factor all of this in. The whole when it comes to policy, it's just not just one aspect, as you have mentioned. So I do think that something to kind of like dovetail towards, because you mentioned the successes of the vaccination campaign in Australia and New Zealand. Like, we are really like, we have a high vaccination rate until prior to Monday, right? So this Monday we opened eligibility of vaccination to 5 to 11-year-old. So obviously the overall rate of eligible population would be lower, because we opened to a new like subset of population. It was like 90% double vaccinated in New Zealand, so that's really high, and now they are saying, cool, right? The reason why we are, and you also mentioned preventing people from coming in to New Zealand, right? To like isolate and prevent, now it's Omicron, from coming in. The premise they are doing this is, one, we want the kids to get vaccinated, right? And then second would be, we want everybody who is vaccinated 4 months after to get their booster shots, right? So I kind of like want to talk about a little bit about the vaccines now. So because we had like a brief overview of like COVID in general, talking about lockdown. So the next thing is like, vaccination is a very important topic because, we have like, I think a lot of people can be really unhappy with lockdowns, but and you probably have a little bit like larger consensus, but vaccinations can be a little bit tricky to navigate conversations like that. And you mentioned it yourself that you've been vaccinated, you got COVID. Both Chung and myself, we've got vaccinated as well. So we're not like anti-vaxxers or anything like that. But I do think even the term anti-vaxxer is like very pejorative because it kind of implies that people do not have rational reasons to not get vaccinated, right? And I do think it's very important. So one big thing that we want to talk about would be, because I think at the start of our conversation, you mentioned Omicron is very mild, like a flu, and then there are side effects of vaccine as well. So you have to like weigh it out, right? What the side effects from the vaccines are versus the side effect from getting the virus. So before I let you talk about that, I just want to like clarify my position. My position is that for anyone who were to encounter COVID, right, it's always better to have, for the first time, right, obviously encounter COVID for the first time, it's always better to have some form of immunity than not, right? That's my position, right? And which means that most likely it's from vaccination, but obviously there are ways to navigate those conversations. So maybe you can share with us a little bit about vaccination, the benefits and the side effects. Also, talking about whether these benefits and side effects apply to every single population demographic the same way, because we know from the literature it really doesn't, right? It definitely benefits the older people more because they have a higher mortality rate from the virus. So maybe you can share a little bit about that topic.
Sure. So vaccination is a very important tool in protecting populations against COVID, but it doesn't protect populations against COVID in the way many people think. It doesn't prevent disease spread. So as you said earlier, Kedrick, vaccination protects the person being vaccinated and only provides limited protection against disease spread. I think by 2 or 3 months, the protection against disease spread drops pretty sharply. And so the fact that the New Zealand population is very well vaccinated is fantastic news for as far as like whether the New Zealand is going to experience a lot of deaths from COVID, but it will not protect New Zealand against getting a large outbreak of COVID. When you open up, and you maybe even before you open up, you're going to get a large outbreak of COVID. It will happen, and so it's just a matter of like time, and like how draconian the lockdown is. Let's just focus then on the private benefits of vaccination, which are substantial. And Kedrick, I think you laid out the issues very well. If you are older, the harm from COVID is much higher in terms of the risk of severe disease, right? So, if you're over the age of 70, I mean, it's a 3, 4, 5% mortality risk if you get infected. Vaccination reduces that risk by tenfold, right? So it goes from from a 2% mortality risk if you're say 70, 75, I don't know, something on that order, to 0.2%. It will save your life if you're vaccinated the first time. And you are absolutely right, Cedric. The first time you meet COVID is vital, especially if you're older, to have the vaccination on board to reduce the risk of bad outcomes. It's a public health priority for the life-saving, not for reducing disease spread. Now, vaccines, just like any medicine, have side effects. You're always in medicine trading off the benefits versus the side effects. You give medicines when it makes sense to do so. There's no medicine that has with no possibility of side effects. You're always considering the benefits and the harms. And here, because the risk that you're averting varies so differently across different people in the population, with age being the number one risk factor, you're going to have different risk benefit calculus. So for an older person, you're getting this huge benefit, reduction in the probability of bad outcomes if you were to get COVID. There are outcomes from the vaccine that are documented in. So, for instance, there's a 1 in a million on that order risk of Guillain-Barre syndrome from the vaccines, from the mRNA vaccines. Tiny risk, tiny risk, much less important than the risk of if you get COVID of dying from it. But it's a fact. I mean, that's so 1 in a million people getting the vaccines are likely to get this terrible Guillain-Barre syndrome as a consequence of vaccination, not because of COVID. And that's mainly an older population, I think, if I've seen the data right. And for younger people, this vaccine, so for older people, you trade off the benefit of the vaccine, which is substantial, against the possible risk of harms, even harms that we don't know about yet. And it just prudentially, it makes sense to say you should get the vaccine. You have a certain large benefit, and you have some uncertain harm that's probably quite low. It's worth it. The calculus is very different for younger people. For younger people, the vaccine is protecting against much smaller harm from COVID. The death rate from COVID is very, very low in 5-year-olds, incredibly low, especially healthy 5-year-olds. And so you vaccinate a healthy 5-year-old, you're gaining almost no benefit, because if a healthy 5-year-old gets COVID, it's astronomically likely. It's like 1 in a million that they'll die from it. At the same time, you have some harms from the vaccine. Young men, for instance, we know from the mRNA vaccines have a higher rate, have a side effect of myocarditis, inflammation of your heart muscle, or in pericarditis, inflammation of the sac that holds your heart. And sometimes that actually can result in death. Now, that's not common. So the myocarditis and pericarditis risk is something like on the order of, there's some controversy in the literature, but let's say between 1 in 3,000 and 1 in 10,000 patients, young men who get it will have it. Most of the time they'll recover from it, but it can happen. It's not pleasant. Young men shouldn't be getting myocarditis. So you have that harm against the relatively small benefit, and it's a much closer call whether you should be vaccinated. Some people are, and now it turns out that the first dose produces myocarditis at a much lower rate than the second dose. So some people have called for only doing 1 dose of the vaccine for young people versus 2 doses. The booster, it's really a question of like the benefits versus the harms, and the case is much closer for young people to say it's not worth it than it is for older people. Older people is definitely worth it.
So that's a really good point, and just sort of like hearing, obviously Kedrick laying the foundation, and Dr. J, you've obviously sort of elaborating on it, just on a very personal sort of like outlook. And I can't say the same for the States, because obviously I've not lived there. The way that the health administration and the government has been sort of like promoting these vaccines to the population, albeit great job on getting 90%. But even, and I won't name names here, but I will say, I'll put my hand up as well. The way that the vaccine was sort of encouraged to be taken, or get it injected into you, seemed like the messaging from the government and the health board was very, very, not necessarily misleading, but it felt like a very forced sort of like approach. And yes, I did get it, but on the event that I did get it, and I was having a conversation with my wife, I kind of told her like, yeah, we will get it. However, it just feels like it was really being forced upon us without sort of the information that was presented. And I did actually have a couple of clients and friends who were actually in the who works in the hospitals, and from what I'm gathering, at least, very, very sort of like not too exposed to the whole COVID thing. From what I'm gathering, at least, is that the vaccines doesn't necessarily stop the spread. It really just stops the side effects of you getting COVID. And a lot of the hospital staff here were actually forced to leave their jobs because some of them were, refusing to take the vaccines. And a lot of the argument was like, oh, you're in the medical field, you should take the vaccine because it will help you to stop the spread to people who do come in. And I felt like there was a lot of, it just felt like the government really sort of like treated really, really, there was a lot of panic in it trying to get the country to 90% so that people don't die. But it doesn't look, Kedrick, I don't know your looks on this as well. It doesn't feel like that they actually presented that information, but it was much more like, we need to get it 90% so that we don't spread it. But it's like I just felt like the way that they were promoting it was not the best. I'm not too sure if that was the same in the States.
No, I think the Western governments and many other governments actually, and certainly New Zealand, have done have I think violated basic medical ethics to get the vaccination rate very high. They've employed coercion rather than persuasion, informed consent, in order to get vaccination high. In fact, governments, including Ardern's government, has essentially demonized the unvaccinated. Sort of created, essentially treated them as if they're second-class citizens. And I think that is going to be, that is an enormous public health mistake, because what it does is you get the vaccination rates high, but you'll create a population of people that view public health as this coercive force and start, rather than a partner in producing good health with the population, it's someone on the outside pushing. And that kind of distrust will result in distrust of public health, other important recommendations. We're already seeing this in the United States. I think the vaccine hesitancy that we've seen in the United States is unprecedented in my view. I mean, it's always been true that there have been some group of people, relatively small group of people, that have doubted the importance of vaccines, that are the standard vaccines in the United States. But that group has grown very sharply as a result of the coercive practices of some places. In the United States, they put in these vaccine mandates where, if you don't get vaccinated, you lose your job, right? You can't enter restaurants, you can't enter libraries, you can't go to museums, you can't go to shows. These vaccine passports, green passes, like what they call them, I guess, in Europe. So you have this like incredibly coercive kind of policy, I think. In order to get the vaccine rate high, and based on the premise that you need high vaccine rates in order to stop disease spread. That's a bad premise, because it's based on bad science. The vaccine does not stop disease spread. And this idea that you can get to and stay at zero COVID is the central fallacy that we've seen throughout the epidemic, and I think it has played itself out in New Zealand in sort of its distilled form. And I am really scared for the future, because I think there will be a counter movement to that as a consequence of that coercive public health. That coercive public health breeds distrust in public health, and it will play itself out in distrust of very basic, important public health advice. And I wonder how future governments are going to be able to cope with that, because it's going to have negative consequences.
I think something that's very important is to be able to provide the information and allowing people to weigh it themselves, right? Make the choice based on the information available. I do think when omission of information is present, it can either be, it may, I don't want to like, I mean, it does seem that like there's a huge element of coercion, but it can also be, it's either like from like, oh, you're coercing people, or the fact that you feel like people are not smart enough to decide from themselves because, oh, these are the information. So I also feel like that's very like paternalistic and undermining people's ability to make choices for themselves. I think a very good, and people usually have huge pushback against them because you're kind of like denigrating their character, and I want to like share an example, like a personal example on like the importance of like sharing information is that my parents, so like I said, they're based in Malaysia, and the older generation from like Asian household, we tend to be skeptical about Western medicine, right? They're like, oh yeah, and then they're usually like tough it out, like parents are from like immigrants, if you get a cold, if you're sick, you're basically weak, you just have to tough it out, right? And all that kind of stuff. So initially my parents didn't want to get the vaccine, right? And they said they made a booking, and I had to ask my brothers to actually check. So my mom actually, like, I don't know whether intentionally or out of ignorance, just lied to my brother, say that, oh, she already made her vaccine booking, right? And she didn't, she didn't want to get the vaccine, the primary dose. And my parents are like, they are both above 60, so yeah, the risk is relatively higher. And my brother basically said that, okay, cool, if you don't get vaccinated, I'll cancel your Netflix subscription. So my parents in the end got vaccinated, right? Out of the, I mean, maybe part of it was like not willingly, but at the point, it's nice sometimes when we grow up and we can like make our parents do things that they don't want, because when you were younger it was the other way around. But besides the point, but now when it came to boosters, right, I told my parents, I said, cool, these are Malaysia, they also got like AstraZeneca vaccine, which is like comparable to the Johnson and Johnson. And my mom was like afraid of like VID, the blood clotting, but I said, yeah, it happens in younger females. And I tried to like persuade my mom to get the vaccine. Fast forward to the booster rollout, I told my parents, yeah, you're relatively older population, makes sense if you get the boosters, but I told them, yeah, my brothers probably shouldn't. And then my mom's like, okay, cool, I'll listen to you, right? I'll take your advice. And yeah, they got boosted, right? I didn't even have to coerce them at all, so I feel like that obviously this is n equals 1, and I feel like this kind of like important when you share the information out with people. People can be more responsive, because I'm sure there's data out there showing that resistance to other form of vaccination, not COVID vaccines, like measles vaccines and all that, they plummeted, because of like skepticism. Because whenever you feel coerced and and not to mention if you're coerced with like something that's not the full picture. For example, say, oh, you take the vaccine so that we can go to COVID zero, but clearly we are not in a COVID zero world. People will be like, man, people are lying to me, So I do think that proper information is very, very important, and it does sometimes feel like certain information is being omitted and conversations are not being had, which I think is like important. Particularly, like even when we talk about boosters, I think Israel, which is like one of the forefront of like vaccine like studies coming up, they recently came out with a study saying that even the 4th shot might not prevent against Omicron infection, right? And things like, yeah, we're not surprised, we're not surprised, right? And not to mention, why are all this like information being omitted, and the false premise that everybody should get boosted, because if we get boosted, right, that will reduce the cases of Omicron in New Zealand. And sure, there's a point of like protections, and if people get less sick, then they won't overwhelm the health system. But I think I've seen data from the States showing that 2 doses, right, even population in the 70 plus, 2 doses are still effective, 94.5% effective against critical illness. And if you take 3 doses, it's 98.3%. So the increase is so marginal, right? And obviously, if you're older, it benefits. But for the young people, right, with myocarditis as well, you mentioned just now, I think a really like high rate of myocarditis is like 1 in like 1,700 myopericarditis, and then you have like 1 in like 7,000 to like 10,000, right? So the conversation should be had. And I think that for yourself, you have been on the forefront of like a lot of like criticism, and especially from public health officials, people who don't know you, I don't know what has been happening. Is like basically you, Martin Kulov and Sunetra Gupta, you basically co-authors of the Great Barrington Declaration, has been like labeled as like fringe, right? Fringe scientists, and you need like a swift and devastating takedown, right? I think I'm quoting the words word for word, and you probably could correct me if I'm wrong, but I do think that the element of conversation regarding specific topic is going to be very important, because when something that puzzles me, like when it comes to university and being someone who is like, when I was younger, I really asked questions of why I like to have conversations about this. There really isn't many like conversations on like regarding matters of like differing opinions, and like there's no debate, there's no public forum, nobody like that. Yeah, basically there's nothing that happened like, oh, a university invite this panel of speakers and this panel of speakers and to debate the issue, and at the end of the day, just stream it free from public for the public. Everybody's on Zoom anyway, nothing better to do, right, to watch, and then they can make the decision for themselves. And I think that has been sorely lacking. If I'm not mistaken, you were in conversation at the start when you had the GBD, the Great Barrington Declaration, with someone from like the John Snow Memorandum, right, at the start. So like they're opposing views, and I think that was the only time. And then there's probably a couple of others, but there hasn't been really any conversation surround this whole topic. Why do you think this is so? Especially you were on the receiving end of like, yeah, cool, right? This person's like a fringe person, we probably shouldn't listen to him. And the Twitter mob, they get really angry and basically just, yeah, you can gather an army on either sides, right? So what do you think like has happened created such a deep divide?
So there's a lot in your question, Kedrick. So let me just start with a very brief comment about your parents and you and the vaccine. I think medical decisions, especially in Asian cultures, and certainly in the culture and the family I grew up with, are often family decisions, and there's nothing wrong with that. I think that personally, I think it's a healthy thing. Like, you want to consult your family members when you make major health decisions, and I think children can play. You're not a kid, but I have children that are on the process of becoming adults, and I hope that they'll play some important role in my health in coming years. But I do think that the medical profession owes it to everybody to treat them like they are rational people, to treat them as not like children. So give people a choice. Say, here's what the data show. Here's the benefits, and here's the harms, and you can make your own decision. That kind of informed consent is incredibly important, and to do it in a culturally appropriate way is an important thing within medicine. And I think I'm glad you convinced your parents to get vaccinated. I think that's very important for especially for older people. I also agree with your characterization of the booster being a marginal benefit relative to the first two doses. The first two doses are incredibly important for reducing the risk of severe disease. For some people, actually, the booster makes sense too, right? So, like, for older people, it might make more sense than for younger people. But again, it's an individual decision. I think that's something that ought to be left to left to people in consultation with their physicians. Okay, so now let's turn from that to you're telling your audience about the Great Barrington Declaration and the John Snow Memorandum and the discussion in science during the pandemic. Okay, so let me just set the stage a little bit. I think for much of the pandemic, especially the beginning, there was and this continues to be an incredible fear and panic around COVID. The World Health Organization told people there was 2, 3, 4% mortality from this disease. It sets people's minds on fire. And that panic led to a huge number of policy decisions that were not very well debated. They were just adopted as if they were the logical consequence of the fact that you have this severe disease floating out there. Lockdowns, zero COVID are among the group that group. Almost from the very earliest days of the pandemic, if you were to try to argue against lockdowns, against a zero COVID policy, which, by the way, is epidemiologically impossible when you have the disease spread into other mammals, you would be pushed back. The pushback would be devastating and enormous. You'd get things like, well, you're not an epidemiologist, you're not a virologist, you're saying dangerous things, you shouldn't be arguing against public health. Essentially, a relatively small group of scientists with a narrow set of expertise dominated the discussion, and in the name of science itself said, we must do these policies, and any pushback to any argument, any dissent around them is dangerous. There was this illusion that all scientists agreed that we must have a lockdown, that suppressing the virus to near zero is the only sensible policy. And the mainstream, the media, many governments enforced that illusion of consensus. I know in New Zealand it was very difficult. You probably haven't heard very many. You're listening to Twitter, but like most people in New Zealand haven't heard what I had to say about this. It just wasn't part of the mainstream narrative. The Great Barrington Declaration. It's a document that I wrote with Sunetra Gupta at Oxford University and Martin Kulldorff at Harvard University. It was a small conference organized at Great Barrington, Massachusetts by Martin Kulldorff in October 2020. He invited me and Sunetra in order to compare notes about what the right policy. All three of us had expressed some concern about the policy that we'd adopted. Our goal was to present an alternative that could really be followed. In fact, it's the alternative that most countries have now adopted, although they won't admit it. and to express concerns about the lockdowns, and mainly to shatter the illusion that there was actually a scientific consensus in favor of lockdown and zero COVID when there really wasn't. I mean, I personally knew, Sunetra knew, and Martin knew many scientists who were very concerned about the policies we had followed, but that were afraid to speak up. And so we wrote this document proposing a strategy of focused protection, protecting the older population who actually are at the highest risk of disease, while at the same time lifting lockdowns on younger people who were harmed more by the lockdowns than COVID. And ultimately leading to sort of less overall harm and death than a lockdown-focused strategy, which you can see is like in the United States has utterly failed, right? 800,000, almost 850,000 people have died from COVID. Lockdowns did not much. Most countries that adopted these lockdowns didn't succeed with them in preventing COVID from taking its death toll. But the goal was to shatter this illusion. Our goal was to shatter this illusion that there was a scientific consensus. Almost immediately after we wrote this, it went viral. Almost 800,000 regular people signed it. Tens of thousands of doctors and scientists signed it within days of us releasing it. Maybe you all signed it. I don't know. The document sort of went all around the world, almost like samizdat. It wasn't spread by the media. It was like a viral document that everyone's like, well, look, sounds like there are actually scientists who disagree with the current policy. That was our main goal, was to start a discussion and debate about how best to protect the vulnerable. Because we saw, at least that the lockdown policies were not protecting the vulnerable. 70, 80% of people dying are people above 65 from COVID in the United States. The lockdown policy was failing the vulnerable. And we saw another lockdown coming. We also saw the lockdown harming younger people in irrecoverable ways. And so we wanted to start a discussion about how best to protect the vulnerable while allowing younger people to live more or less normal lives. Instead, what happened was this sort of deplatforming, this like vicious propaganda war to make us look as if we were fringe science. Martin Kulldorff is one of the people primarily responsible for designing how the FDA, the US FDA, tracks vaccine safety. Sunetra Gupta is probably the world's premier epidemiologist. She's at Oxford University, and I've worked on infectious disease epidemiology for decades. We're not fringe. I personally have been funded by the National Institute of Health. It turns out, when we learned later, that the head of the National Institute of Health in the United States, Francis Collins, and Tony Fauci, the head of the National Institute for Allergy and Infectious Disease in the United States, within 4 days of us writing this declaration, organized a campaign to make us look as if we were fringe scientists, to organize popular media outlets to marginalize us. And in generally, just rather than engage with us in a discussion about the nature of the policy that we were proposing, to essentially propagandize it, to say that I was in favor of, for instance, letting the virus rip through the population, which was a lie. I'm not in favor of letting the virus rip through the population. I'm in favor of protecting the vulnerable from it, because that's the right ethical thing to do. And I think that it really poisoned the well, right? And the goal was, the reason why you saw this furious, and then there was this like counter document in the Lancet written by some very prominent people, including the current U.S. CDC director, arguing in favor of lockdowns with falsehoods, like that natural immunity doesn't happen after COVID recovery. I think what you ended up seeing was this like furious counterattack in order to maintain the illusion that there was a scientific consensus in favor of lockdown. And unfortunately, they won the policy war. They got the lockdowns they wanted in the winter of 2020 and 2021, I mean. Despite that, the COVID spread throughout the Western populations. and wreaked huge devastation. We've had like wave after wave of COVID despite these lockdowns. So we've had both COVID and the lockdown harms. If we'd had that discussion, an honest discussion about policy in October of 2020, rather than the propaganda war we actually saw, I think the world would have been in a much better place.
Yeah.
It just seems that it's interesting because I'm not too sure whether the New Zealand health officials obviously had a discussion in regards to how we handle COVID over here, but it just seems like over in the States, at least from what I can gather, is that there's always going to be people trying to push the agenda just because they think they're right, and not willing to having a discussion, a proper sort of like open discussion, in the likelihood that they might actually come out, quote unquote, on the losing end of it. And it feels like politics these days, especially when it comes to, as we've seen over the last couple of years with COVID being, just running through the world, it seems like politics these days are more about trying to, and science to a degree, I would say, and it's trying to be the positive and the front facing, I'm the best in making the decision in mainstream media, rather than trying to think of what's best for humanity, essentially. And it seems like ego is a big prevalent thing, especially hearing your story, Dr. J, with obviously the policy that you've guys come up, essentially losing out to someone who might have more pull in the media.
Yeah, I mean, I think just to like try to elevate this a little bit, if in science, you don't know, there's no one can really reasonably say that I am the science. Like that is not something that anyone beyond a narcissist would be able to reasonably say, right? No human is possessed of all scientific truth embodied within him. That is just not right. Science is a process by which people reasonably discuss with each other. They have different ideas about how the material world works, but you temper that discussion with data. You ground it in data, in testing, in logic, and you end up with something approaching the truth as a result of it. Sometimes over a long period of time, because these problems are challenging and difficult and not obvious. So there's this norm of free and open discussion of people, even who might disagree with each other very, very vehemently. But that kind of open discussion leads to progress in science. Now, in public health, the norm is a little bit different, right? So public health has it has to communicate with the public in a clear way, and the message just has to be as simple as possible to actually have an effect. And if there's a lot of disagreement among public health people, that clarity gets lost. So there's a norm in public health of not having a lot of debate in public messaging. Now, you will have a lot of debate among public health people behind closed doors in journals or whatnot, but the messaging is always as clear and as simple and as non-contradictory as can be. So for instance, I tell you the public health messaging is smoking is bad for you. And if I go around saying smoking is good for you, I've done something, I've committed a sin, right? I'm telling you something that's going to harm you using my authority. That would violate a correct public health norm against that kind of thing. I would never do that. Now, the ethical basis for that kind of messaging in public health, for reducing the amount of discussion in public between public health people, is that there is really a strong scientific consensus in favor of the message that public health is giving. If there is not a strong scientific consensus in favor of then the public health people are doing something very, very wrong. They've squelched the debate in science in order to present the message that they want to put forward long before their consensus is actually developed within science to justify morally that squelching of debate. And so what's happened here is essentially, rather than discussing the fact that the scientific evidence was not, the scientists had not come to some conclusion about the wisdom of lockdown, they squelched that debate in order so that they could keep the public health messaging simple as possible in favor of lockdown. I think they violated a basic ethical norm that underpins the why in public health you would normally be able to give a unified message. You have to have consensus in science before you are allowed to do that in public health, and they violated that rule.
I also think that something that is like important is for people to understand what science is, right? So for the most part, we know that science is like descriptive, right? It's not prescriptive, like the philosopher David Hume like famously said, there's this is odd gap, right? Just because something is doesn't mean you ought to do it, right? And science is like that, right? It describes certain parts of reality, but it can't tell you what to do, because people can obviously adopt unscientific approaches to things, so it's not necessarily prescriptive. And I think that you mentioned a very important point of having that debate, especially when there's uncertainty, and we've seen this during the COVID pandemic. I think that like you mentioned, the current CDC director, Rochelle Walensky, right? So she basically, one of the people who was in the Jon Snow memorandum writing against what you've put out, recently said that we should now focus on protecting the vulnerable. I'm like, so, I mean, you and your co-authors and whoever that signed the declaration probably felt a little bit vindicated. But I also do think that you have to kind of understand that I saw like some stats online, not sure how accurate it is, but I don't think it will be that far off, is that trust in public institution prior to the pandemic was already quite low, like around 40, like less than 50%. And, what has happened now has sown further distrust, and public health will take like a long time to recover, unfortunately, and like you said, the consequences can be pretty devastating, and I do think that for yourself and your co-authors, like out there, putting yourself out there it's quite brave. It is crazy because I've seen, obviously these are like really like extreme stories where people like personally like get threatened. I mean, whether people like the message from our prime minister or not, on how she implement policies, I don't think people should go to the point of like sending letters like, oh, I'm gonna like threaten, like send death threats, right? I think that's just really bad, regardless of which side of the debate you tend to support. But yeah, I think that we've come to a point that the pandemic is not about the virus anymore. When I first got into all of this, it was during like lockdown, and there was an article out there written by certain like public health people. So like the people that the government consult. In a way, you can say there's a New Zealand version of Francis Collin, Fauci, and Walensky. This is the New Zealand version. One of them said that we can't let COVID be endemic, because if that happens, we will have thousands of deaths in New Zealand. But that this happened during the Delta wave, and vaccination rollout was already there, right? But nothing in the article mentioned about vaccination preventing death. And I was like, wait, it doesn't take me, I'm not like a virologist, I'm not trained medically to see that. Isn't this like a contradictory message? Because you want to get people vaccinated, but you fail to mention how vaccination can actually prevent that. And I basically wrote an article and like published it on my Substack, because none of the outlets wanted to like publish it. I don't know why. I don't want to speculate, but I just said like, it's fear the new pandemic, right? So like this fear, this panic, and I think it goes back to what you mentioned at the start of our conversation, where people think that the IFR is like really high, like everybody would die, and this has caused a lot of problems. I think I saw online where people say like NYC emergency hotlines are being overwhelmed because everybody that has like a cold or cough or fever, they start calling 911 for emergency because they think they're gonna die of COVID. I have friends who work in Victoria in Melbourne hospital. He works as a nurse, and they said that they have like Victoria has one of the highest cases of COVID outbreaks there. And he basically told me that people were just too lazy to either like get proper testing, like in like from a PCR test or whatever. They don't want to line up and wait, so they just walk in the hospital because they know the nurses and the staff will not refuse them. And then the hospital just get overcrowded of like free walk-ins. Like the message of fear and panic is like, dude, if I don't get tested now, I'm gonna die, And definitely there is some merit for certain people, like for example, like monoclonal antibodies, all of that. Early treatment would be great, but like I said, the likelihood of someone who's like 25 getting a cold, dying is already really low. And ironically enough, those people who are 25 are the ones that would rush into the hospital first to get tested, and then but whereas like the people who's like older may not even have the physical capability or even like the capacity to go to get tested first, so like there's this like really big like disproportionate impact, like you said, the vulnerable they don't really get protected. And I think a big part of messaging, I think this is really important as well, because you are kind of like you also do work in like economics, and the thing with focus protection is that I think it's so important because with a finite amount of resources, you need to channel those resources with the greatest return of investment, right? And unfortunately, resources in this world are finite, right? So, the thing is that if you lock down the country, lock down the economy, you will not be able to replenish your resources that you're currently channeling into potentially useless and arbitrary policies. And like, I mean, just look at the world now, right? Like inflation is like everywhere. So it does speak a lot on like the economical aspect as well. I think New Zealand had like thousands of over businesses deregistered across the 2 years of the pandemic, right, during the lockdown. And like I said, school closure in the States. I also have heard that some teachers telling me that the grades were marked more leniently, right? So the standard is lower. So obviously the quality of education has dropped as well, which means that potentially if this carries on, people who have an equivalent year of education prior to the pandemic versus during the pandemic, right, the quality of education would be lower, right? So society as a whole progress would be like diminished. So there are, like you said, multiple factors. I have a lot of thoughts, as you can say, but I don't want to take up too much of time. So how much time do you have left roughly?
I mean, I can go for a little while longer. So let me just comment on a couple of things you said. So a lot of public health in the rollout of the vaccine, they made the mistake of thinking that this vaccine could be used to eradicate COVID. And as a result, in a very weird way, by overselling the vaccine, they also undersold it. So like the vaccine reduces the mortality rate from COVID very substantially. But they were afraid that if people got vaccinated, they would start to live their life like normal again, and then COVID would spread, which would contradict their goal of zero COVID. And that actually, I think, led to many people underestimating the importance of the vaccine. It was actually an anti-vax message to say that, because so if I get the vaccine and all of a sudden you're telling me I need to have a mask, I have to like social distance, I still have to do everything that they were already telling me to do, a natural response is, well, why do I get the vaccine? What has it done for me? So I think that and the root of that problem was a confused idea about what the end goal was. The end goal is it could not possibly be zero COVID. No matter what we did, we were going to end up with COVID being endemic. That is not avoidable. The only question is, how do you minimize the harm from the policies and from COVID until the point that COVID is endemic, right? So there's no strategy that leads us away from endemic COVID. That is just that was baked into the cake in March of 2020, February of 2020. It was already too late for the world to not have COVID endemic from almost the earliest days of when we realized that we were in a pandemic. And so they had these like very strange messages because they got the goal wrong. It actually, I think, undermined confidence in the vaccine at a time when it really needed to like sort of boost confidence in the vaccine. And they could have done that if they just focused on the thing the vaccine does so well, which is protect against severe disease. So I think that is something that I think it's just a basic lesson. If you have the wrong end goal, you're going to end up with the bad tactics to get there. If you ever play chess, you see this all the time, right? You have the wrong idea for a plan, and whatever tactics you do end up being useless. You get checkmated. That's essentially what's happened with public health. It didn't understand really what was possible. And I think now we're finally gotten to the point where I think most countries realize that endemicity is going to happen no matter what we do, and they're starting to realize that the harms. Like I think the UK just opened up today, said that they were lifting almost all COVID restrictions. Unfortunately, I think Australia and New Zealand is still not quite there. New Zealand, I think, still has a hard road ahead to get there. Australia, you're seeing the cases just explode. I think we're in a position where I think we're going to start to see some changes in Australian policy as they realize they can't stop COVID from spreading everywhere. And then there are going to be hard discussions about what was done in the name of COVID control and why it was done.
I think it's always that whole play on fear, and I think this will, I guess, traverse from sort of like continent, country to country. We obviously saw that in China, where the cases spiked. Obviously, that's where it claims to be originated from, and everyone did something there. It went over to Europe and the States. It spiked. Other countries saw this and said, "Oh, we're gonna protect ourselves and shield ourselves away from everyone else." New Zealand, Australia. And I think it's kind of that. I do feel, and I'm kind of a little bit worried as well, potentially, I think for Australia and New Zealand particularly, as I've kind of had a lot of conversations with friends who are in Canada and in the States. You guys are essentially in a position, as much as how to put this, living with COVID essentially. But over here in New Zealand and Australia, it seems like we haven't got that message. It seems like that the public hasn't really accepted the fact that we need to live by it. And I tell
you, like, the problem is, like, your government has lied to you, right? The government has spread the idea, and it's used the levers of power, including the mainstream media, to spread that lie that you would be able to maintain zero COVID forever.
And I can only imagine, like, the fear when like the media starts posting, we go from 100 cases to 1,000 cases overnight. And that's basically what happened with that second lockdown, right, Kedrick? It was it's funny because both of us, we flew somewhere else for meetup for a competition, and the day of, how ironic, the case went from like 2 or 3, and all of a sudden the media is like 200 cases in a day, and everything started closing down. Like, come on, like, we knew this was going to happen, but clearly the government hasn't psychologically prepped the people for this. I think the government should have done
quite the opposite, right? Quite the opposite. They've instilled fear, like unreasonable fear of COVID. I mean, the right thing to do is tell people the truth, right? There are groups of people that are really vulnerable if they were to get COVID, the older people, and give those older people tools to try to be protected from community spread when it happens. And those tools could have been, there's lots of things you could do, like to better protect nursing homes, like good high quality masks, testing for people that come in, changes in how, like, staff rotate in and out of nursing homes. You could even made nursing homes into places where staff actually that's where they live for a month. So you reduce the amount of, like, the traffic in and out of nursing homes. That's where like 40% of the deaths are in the United States and in many other places. They could have done all kinds of things to try to protect the vulnerable. On the other hand, it's just like, it's, if you're going to say, like, evaluate the New Zealand policy fairly, it did work, right? Because of the vaccines, it worked. Older people, there are going to be fewer older people dead of COVID as a consequence of the New Zealand policy, because the vaccines were developed, but it is coming at a very high cost to New Zealand in terms of the lives of the young people there.
I think the big thing, right, is so important is how people treat one another. I remember this story. So we have had 3 lockdowns in total. The second one was like very, very short, like briefly, like just 2 weeks, because we had like some community case, and the first instinct is always to lock down, unfortunately. And what happened was I was in a different like city, right? And they always lock down Auckland first because that's where we are, right? The big city, right? Auckland, and that's where the spread usually happens. So I was in a big city, in a different city, right? Up in the mountain, close to the mountains, and then they announced a lockdown, which means I had to travel back, right? So everybody had to travel into Auckland, and there was this massive like jam, right? The jam was like long, and then I said, cool. I was with my friend, and I was like, cool. There's this ice cream stop here. There's this ice cream stop here. Let's get some ice cream. Just chill for a bit. Let's wait for the jam to subside. Then we go back. Then I went there. There was this like lady. She was having ice cream, and then she asked, "Oh, where are you from?" Then I said, "Oh, we're from Auckland." Immediately, she took like 3 steps back, or like try to distance herself away from herself. Like, dude, like, I'm not gonna spread COVID to you, like. And this is how like people treat one another, and it's just because they are so fearful. So sometimes I don't really like blame them, because if you think that if like, in the olden days you have like leprosy, where they like basically like isolate the lepers from the like general population, and if I touch you, you're gonna die, right? Sure, you will fear for your life, but like I said, the actual harm towards most people is actually marginal, and I'm also really concerned on how things will happen. I think about like, you mentioned masking in kids, right? Besides the learning disabilities that might happen, I'm also thinking of like how parents would tell their kids, oh, if your friend doesn't mask, you can't play with him, And the thing with kids is that kids would pick on kids. If you have everybody in the class that masks and one guy that doesn't, right? Or let's just say his parents think that they don't need to mask, people will like isolate that kid and like.
I mean, I think what you said is really important, right? So there's this like, it's almost, I mean, I for want of a better term, it's like a spiritual effect, right? When we're like made to be in community with one another, like humans, we're not meant to be isolated, separated, fearful of one another. When we interact with each other, we should interact with each other as fellow human beings that we learn from, that we treat with respect and love. What the COVID policies have done is it's trained people to think of each other as simply bags of germs to be avoided, sources of infection and contagion to one another. And a society cannot function like that. A society cannot function when everybody thinks of each other as just a source of harm for us, rather than a source of enrichment and love. And I think that is going to be, that's sort of underplayed damage of the lockdowns that will last a long time. I think I don't know how you get out of it when we spent the better part of 2 years reinforcing that message over and over again. I think humans are built with this, like we have this like built into us, this like almost evolutionarily, this fear of infectious disease. Many Western countries have conquered it for decades. And so when COVID arrived, this lizard brain center of our took over for so many people, and governments reinforced it, so that we were so scared of contagion, we started treating each other much less well than we ought to have. And I agree with the harms of the masking children. I don't really understand how you can look at if you're a disabled child. Like I've heard from many parents of autistic kids being forced to wear masks every day is very difficult, or deaf kids that need to be able to read lips in order to be able to learn to communicate. How do you do that in a masked environment? How do you teach a kid to read when the teacher is, the 5-year-old is learning from a teacher who's masked up, and you have to look at the expressions on the face? A lot of that is quite important in social and emotional development for kids. To pretend like that's a costless thing, doesn't make any sense to me.
Yeah, not to mention like the actual impact on kids itself is not as high, right? So just something like anecdotal in New Zealand, we have like some outbreaks, right? And a lot of like cases happen in school, but I don't think a school has ever been a super spreader event, right? Prior to Omicron at least, right? Because that there's multiple reasons why kids don't really they're not like good vectors of transmission. But the super spreader events itself were not from schools, they usually happen with like events where they're actually adults in it, So I do think that, like I said, the policy, like this impacts people differently, and there should be some form of like individualization on how you handle matters. And the thing with mandates is that without mandates, right? I'm not saying that you can't mask, if you want, you can make a choice to triple mask, wear a face shield, wear a hazmat suit if you want, right? If you want to dress up like it's Halloween every day, go ahead, but with mandates, you literally don't have the choice, whatever, So I think that is the thing. I spoke to people about mandates and say, I think my problem with mandates is that health, right, should be individualized. Like Chung and myself, we both work with nutrition, and we talk to people who have like different nutrition requirements, and we individualize the nutrition for them. Health is the same manner, but a mandate literally said you can only do this one thing, and it's not individualized at all. Now, I don't know. I hope like when it comes to boosters, right? I know Stanford, for example, John Hopkins, they all started mandating boosters for like college students, right? I hope that it doesn't reach this point in New Zealand, because like you said, the effect, even the increase of severe illness is so marginal for even people who are more vulnerable, right? It's like 3-4%. It's going to be less in people who are young and healthy, right? Not to mention that if they already have your primary series, right, which I assume most of us would already have here, there is the risk that you have to outweigh, like for example, I think the things that Paul Offit, who basically created the rotavirus vaccine in the US, did, he's like one of the most like pro-vaccine advocate. He also said that, I know there's some pushback within child vaccination, but I think Paul Offit said that, cool, right, we need to I think vaccinating children, even though the data set is not high, because in the trial for Pfizer 5 to 11, they have a small sample size of like a couple thousand people. So he said that, I think that the benefit outweigh the risk. That's up for debate, but it does show that he's leaning more towards a pro-vaccine side rather than not. Said that he didn't recommend his 20-year-old son to get the booster shot, right? And so it's going to be very individualized. And until you have the conversation, on individualizing healthcare for people, I think you go down a really slippery slope. What if you come back like 3 years from now and let's just say, I hope it doesn't happen, but like a lot of people were affected by like myocarditis, right? Especially in New Zealand, where transmission is really, really low. It's very different where in a high transmission setting, the higher the transmission is, obviously there's likelihood of you getting infected that's high. But if your transmission is really low, you probably don't need it. Like a really good example would be my friend. So my friend is in China and he's not vaccinated at all, because he said, I don't need to, because the Chinese government has a zero COVID policy. So if there's any outbreak, the government will just have draconian measures and lock the whole city down. And I'm fine, like I don't really get affected because the transmission rate is almost like nothing. So he lives in China. He tells me that I don't need to get vaccinated because of this reason. And obviously he's a young male. So it's like, yeah, cool. If I don't need it, why should I take it, right? So it's going to be very different. And you apply that to young males as well. Now that if they are recommending boosters for everyone, right? For say everybody should get boosted after 4 months is up, right? The thing is that we know that if you space out your doses, the likelihood of myocarditis is actually lower, right? So, but now you say everybody should get boosted, right? And the next step is like, oh, cool. If everybody is boosted, it's definitely a slippery slope, but why not mandate boosting?
Well, the thing is like there are vaccines that are mandated in many places, childhood vaccines. Many of those vaccines, there's a few things about them that are quite different than the COVID vaccine. So one is that, like for children, for instance, the vaccines provide strong protection against diseases that are really deadly for children. Right? Measles is a deadly disease for children. Mumps is a deadly disease for children. These are diseases that are really harmful to children to get them. Polio is disabling and deadly for children. Right? So those vaccines, if you mandate it for children, are providing a very strong private benefit for the children. It also provides a very strong public benefit, right? If you get the DPT vaccine, you're not going to spread diphtheria, you're not going to spread pertussis if it happens to ever come up in your spread in your region. So they're neutralizing, sterilizing vaccines that protect both the person that's being vaccinated and others. And there you have some justification for mandating it. The other thing about those vaccines is they've been used for decades. Like we have a lot of experience with them. There's much less uncertainty about their safety profiles than there's with this vaccine, because with this vaccine, we've only been using it for a year. To mandate a vaccine like this in this setting when you have such short duration of experience with it at population scale, it just invites disaster, right? It invites groups of people that are going to be some people will be harmed, and they're gonna create a vaccine resistance movement that didn't exist before. And that's, I think, what we've seen as a result. It was just so short-sighted for people, including Paul Offit, I think, has said, argued in favor of the vaccine mandates in this context for COVID. It was just short-sighted, I think, to have that support from public health for these kinds of coercive policies. I think it will harm public health, and already has harmed public health as a consequence of the population saying, "Well, I'm not sure. You haven't convinced me yet." Our job as public health professionals or as scientists is to help convince people, give people the evidence, and then help people make the right decision, not to force them or coerce them. That itself creates distrust. And I don't really understand how it is that many other people and prominent people in public health don't see this. It's as if they, again, have been so focused on COVID that they lost sight of all else in their life and in public health, in the life of public health.
Yeah, it's always going to be a slippery slope, especially when the public health sort of like puts it like, we're not mandating vaccines. However, and they start to have like a huge list of things that you can't do, or
there's coercive policies. It's like,
it makes it so hard. It makes it so hard. Like last week I just got on a plane and went for a bit of holiday and came back, and in New Zealand at least, it was you either need to have your vaccine pass uploaded so that you can get on a plane, or you have to get a test 24 hours before your flight. Now, in my head, it's like getting a vaccine pass is so much easier. It's convenient, and it's like, we're not mandating it. However, the way that it seems like public health, the way that they frame it is that they're trying to avoid the use of mandates. But the way that they are framing it to the public, like you said, Doctor, it's just causing so much distrust, and it's just going to be a slippery slope, especially when they start to do things like, you need to be mandated to do this. Apparently, like this just a couple of hours before we started this recording, apparently they said, at least in New Zealand, it's like, if ever there was an Omicron case, they will move the entire country back into the highest level. It's just going to cause so much distrust, because when we were at the higher level, so much stuff has already happened, like bad stuff, and people are going to be even more resistant to that change. And it's just very concerning that they're using fear and the play on words in order to basically just force your hand without you uttering the words that we are being mandated for.
It's such a like everyone sees through that, right? Like if your job, if your schooling, if your ability to like participate in the social life of the country is premised on the vaccination, in what sense is it voluntary? It's so not bad. And so like I mean, that's just nonsense, right? So that kind of coercion has a very, 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 very limited place in public health, and certainly not in the population scale that has been used in this setting in COVID.
Yeah. I think a large part, so just to clarify, that like the highest level, so in New Zealand we have something called, like, they call it the traffic light system. So it's like a tiered system. Red is like the highest level, orange is like mid-tier, and then green is where basically like transmission is low. So right now most of New Zealand is in orange, and in the event of there's an Omicron case, they will go to red. Unfortunately, like the thing with the policies are like, this traffic light system only affects people who are not vaccinated, and we know, right, that for Omicron, whether you're vaccinated or not, it doesn't matter, you still spread it, which means that you are essentially still marginalizing the unvaccinated group by going through the systems. Like, it doesn't matter, because I would say the big difference, and Chung will probably agree, is that is the size of the gatherings, right? So red, you're limited to 100 people who are vaccinated. We also have size gathering limitation, even though you're fully vaccinated. So at red, only 100 vaccinated people can be in a venue, which means you can't have like music festivals. So essentially the difference is that vaccinated people, the difference between the tiers is that it's the same for the vaccinated people, except you can go for music festivals. Whereas the people who are unvaccinated, you can only get essentials, right? So the thing is that it's so unfortunate that even this restriction, which I don't agree with, is not based on the current science, because Omicron affects people who are vaccinated or not, right? And there's some countries like Denmark, right? I think like one of the countries in the UK, I can't remember whether it's Scotland or Wales, Israel, Iceland. They show that even people who are boosted have similar rates of infection per 100,000, right? So it's not like the absolute number, because people say, oh, it's like the absolute number, but per 100,000. So it's like, cool, it probably doesn't matter. And people has called Omicron like the great equalizer, meaning everybody can get it regardless of vaccination status. But yet they are still trying to like marginalize this small group of people who are unvaccinated. And it is
that was true for Delta too. Like a lot of vaccinated people got Delta. I mean, I was vaccinated. I got Delta. I mean, you're absolutely right. Like it makes absolutely no sense, Kendrick. Why would you treat unvaccinated people as second-class citizens, as if they're pariahs, unclean, when in fact everyone can spread the disease, both vaccinated and unvaccinated? Even if it wasn't true, is it really right for a government that's committed to liberal democracy, to human rights, to carve out a group of people, label them essentially as second-class citizens, and treat them as if they were social pariahs? That is wrong, even if it were true that the vaccinated don't spread the disease. I think a lot of governments have just forgotten themselves. Like, what does liberal democracy mean if I'm an expat and I can't come home to bury my dad or something, right? I mean, that's happened in Australia. I think it's happened also in New Zealand. But you can't actually. What does citizenship even mean if you're going to be treated like that? Insiders, outsiders, that we've created throughout the pandemic, these sort of like out groups, like masked, unmasked, the unmasked or unclean, right? Did you get COVID? Where'd you get it from? You got COVID. I never got COVID. I'm good because I follow the rules. You didn't follow the rules. Vaccinated, unvaccinated, boosted, unboosted. All of these are just essentially tactics that ought not be used by democratic governments, where you create an outgroup that become the source of public hate, public distrust, public repugnance. It has consequences for the trust in government. It has consequences for the social fabric that are very hard to undo.
Yeah, I think, like, say, politics plays a big role. Unfortunately, like, I think the big thing in the politics in the States is that what happens if everything that is currently being done was actually said by Trump? People react differently. So that's a big thing. I think New Zealand is like that in a similar extent. And I don't think we will go into lockdowns, right? Because of this reason, is that elections is in 2023. So if we go into lockdown, right, and Auckland would definitely be the city that goes into lockdown, and a huge chunk of voters would probably
swing to the other end.
They will swing. So that's why they didn't immediately lock down. Because when we had Omicron, so when Delta came, we had one Delta case and we went to lockdown immediately, one in the community, right? But Omicron, I think they're a little bit more hesitant because of elections. But I also do think that you do see a certain percentage, right? So I'm not trying to, this might be complete speculation, so this is not fact, right? That you see that, cool, you have X amount of people, right, agreeing with me, right? And therefore, if I'm a saint to them, I preserve the lives of X amount of this many people. I prevent deaths and all, but most of the facts, yeah, cool. You just because you're in New Zealand, you did that, right? So it isn't really, you had some luck, right? But that you have X amount of people that likes this. So I'm just going to continue with this to appeal to that. And hopefully, if I keep appealing to them, I'll get voted in during the next election. All right. Unfortunately, that I feel might be a thing. Because at the end of the day, unfortunately, people will say science, the truth and politics, it's like oil and water, unfortunately. And this is what we see. So this is pure speculation, and I do think it has like you said, devastating effects. The social fabric people are very tribal in nature. If you read work from Jonathan Haidt, I think a big poem, a poem he quoted in his book saying that me against my brother against my cousin, me, my brother, and my cousin against strangers, right? So we always find ourselves to kind of target the out groups. And by actually labeling people with exact labels, it's so much easier to target the outgroups. I think like said, boosted, unboosted, vaccinated, how many doses you are, we wear it as a badge, right? So unfortunately, like this is like, these are the devastating effects of just poor policies, and it does sort of like extend beyond just, cool, does this person get the disease or not, right? And it has like evolved into something
it's like getting the disease is a moral sin. You haven't been careful enough. You're a social pariah because you got sick. It's disgusting. Like that kind of politics has no place in liberal democracy.
And
we should treat people who are sick with compassion and care, not demonize them for.
And I think a lot of this also kind of stems from and I'm sure that this rabbit hole will continue on for days. We can go down so many tangents, but I think it also stems a lot from how the older generation gets information about COVID, and it's like it's fatal to me, and they start to, I've got a couple of friends, I'm not going to put names here, in Malaysia, where when COVID was very, very high, basically their parents and grandparents kind of told them, like, don't come and visit me, because I don't want to get COVID and die. And it is so demoralizing, because as obviously as a younger individual, you kind of want to spend time with your elderly.
I mean, and unfortunately that's not just older people. Like a lot of the misperceptions about COVID risks are universal. Like people vastly overestimate the death rate from COVID, especially even young people overestimate the rates of, like, long COVID. They overestimate the rates of death from COVID, hospitalizations from COVID, even for themselves. And it's that fear that's led to so much of the pathologies we've been discussing.
So I think, like, just to close things up, I think, like, the world is, I mean, these are outliers, right? So I don't want to think that I don't want to paint the picture that the whole is like that, but I've heard, like, in the States, a parent like locked their kid in the trunk because they suspected the kid has like COVID, and the parent didn't want to get infected. I'm like, since when do we come to the point where a parent who should be taking care of their child actually lock their kid in the trunk? Like, that to me is just like absolutely like preposterous.
I mean, I almost feel, I feel sorry for the kid, obviously, but also for the parent. Like the mind is so filled with fear. It's not even their fault. It's the fault of public health. It's the fault of governments for like creating this panic and fear. Instead, I mean, like, the right tool, the right way to deal with a pandemic is always to provide public health should be always providing a calming influence, helping the public deal with the fear that might come naturally, not stoking it, and then providing tools to protect the vulnerable. That's how we've dealt with every pandemic for the last 100 years has involved some variation of that focus protection strategy, the strategy of keeping society going while trying to protect the vulnerable, not spreading panic, instead conveying calm. And we have just tossed that pandemic playbook aside during this pandemic for no good reason and to disastrous effect.
I think so I think just to close it up, to end it, like, what obviously, like, for yourself, like Chung, myself, we do want to see things improve from here on out. We may be skeptical. So what, to end it, like, what is a message you will send, like, to all our listeners out there? How can they think about, like, COVID, and hope, so that we can hope that the world will progress to a better place in a way.
I think the response, the failed response to COVID, the disastrous responses we've seen to COVID around the world, actually presents a huge opportunity to reform science, to reform public health, and to reform the relationships between governments and people. I think if we are honest about what has gone wrong, we will have the chance to try to make things right. Not only just to do better in the next pandemic, but also to like, I think the COVID revealed a lot of pathologies that predate COVID, in how governments work, in how science functions, how public health functions. And those are opportunities. Those now we have an opportunity. Now we see clearly how poorly those systems function to try to reform them. As long as we can honestly discuss with each other what's happened, there'll be people who have very strong interest in trying to maintain that they did everything right. The governments that are responsible for this, public health officials are responsible for this, and the people have to hold them responsible so that we can have an honest assessment and then actually fix things for the future.
Cool. So as we usually come to the end of our episodes, we generally always ask our guest, Doctor, about, so the title of the podcast is Taking It Back to Square Quan, to play in words, because both of us have the same last name. However, we are completely not related at all. So I guess my question for you, Doctor, is knowing what you know now, seeing that we've gone through a couple years through the pandemic, few years, knowing what you know now, taking it back to square one, what would be the policy or the structure for the world to move forward when COVID have hit, knowing what you know now?
I mean, the right policy would have been focused protection, right? We knew from the earliest days of the pandemic, it was older people that were really at risk. We should have moved heaven and earth to structure our pandemic response to protect the older population who was at most risk. And at the same time, we should have worked very hard so that we could give tools to younger people so that they could live lives as normally as possible, given that there was a pandemic raging. Right. So that would have involved a lot of disruptions, but not nearly the level of disruption we've seen, and would have been much more effective in stopping, protecting older people. I think that template and at the same time, we should do there's some good things that have happened that we should have done, and I'm glad we did. Like the development of the vaccines is a fantastic example of a huge success in such a short time. We also should have invested in the development of early treatment, the development testing of early treatment. That has been a major failure actually during the pandemic. We had, in fact, a demonization of early treatment that should never have happened. And somehow, like, people in public health have treated the possibility of early treatment as a bad thing, which is astonishing to me. So I think that kind of template, or mobilize the scientific community to develop treatments and vaccines, epidemiological public health perspective, protect the vulnerable, and then convey calm and provide tools for the rest of the population to keep society functioning as well as it possibly can in that context. That's the template that will work with not just with COVID, but with almost any infectious disease pandemic.
Well, you hear it here first, folks. Well, this has been a great episode. I don't know about you, Kedrick, but I've took a lot from it, and it's been a great, I don't know how long we've gone for, but I think first and foremost, thank you, Dr. J, for actually taking a time out of, I'm sure, a very, very busy schedule already to come and talk to both of us. Usually we ask this of our guests, where would people find you? But I'm sure, as you might have picked up at the start, Twitter seems to be the place.
Yeah, I've been pretty active on Twitter since September, so it's kind of a new environment for me, but it's a nice communication tool.
Yeah, there you go, guys. Well, hope you enjoyed this episode, guys. If you liked it, give the episode a thumbs up if you're watching on the YouTube. Share it to people who you think might benefit from this, and we will catch you in the next one. Thank you.
Thank you. Take care. Good luck, you all. Bye now.